We'll start our recording. So welcome to the conference today. Today we're going to be talking about B-type natriuretic peptide, and our cardiac fellow who did such a great job eloquently last week, Nick Koch, is going to be presenting his insights and the literature on B-type natriuretic peptide. We've been using this for some time. We were the first hospital in Florida and first hospital in the Southeast to use B-type natriuretic peptide, or BNP. And as a matter of fact, we would transfer patients and people would wonder, well, what is this BNP? And so actually we had to create a website and put everything on a website as to what BNP was. And we started collecting our cases and we put all that together on a website. And then finally BNP sort of caught on nationally. It was called the poor man's echocardiogram. That's what it was called when it first came out. And so we've gained a lot of experience. I've used it quite a bit on patients looking for chemotoxic reactions, on patients with cancer who are getting potentially chemotoxic chemotoxic chemotherapy, and so that can be cardiotoxic. And so we've been using it for that, and Dr. Lenihan did some research on that, saying greater than 250 was a cutoff number. And then I've been using it for years now on patients who have mitral valve disease that's significant with mitral regurgitation, who are being entertained for as candidates for mitral valve repair. And again, that's been predictive of the onset of symptoms by 6 months. And so that's been particularly useful for me. So that's been some of the uses. And then in the emergency room, when we see patients who come in who are female, they don't seem to have as quick an elevation. Their troponin for some reason, but their BNP can be sky high, and those patients are really high risk. So those are some of the groups that we've distinguished how much BNP has been helpful. So without further ado, Dr. Koch is going to get started on his review, and should be very interesting. Feel free to comment and ask questions after we get through.
Good morning, everyone.
You've got that showing.
Oh yeah, let me.
That's down here. What you want? It's right there.
Good morning. So my name's Nick again. We talk about BNP. You know, for a lot of us currently in training, we may take this kind of for granted that it's been around forever. We use it probably every day, certainly in the hospital. And a lot of this stuff is pretty familiar to us, just the basics of what it is and how we use it. But we may not have ever kind of driven down into the, where did it come from, what is it, how did, the data behind it. So that's kind of the premise of today's talk. So when we talk about BNP, we'll back up a second, talk about the natriuretic peptides. These are neuroendocrine peptides, we'll call them NPs for now. And they really kind of oppose the activity of the renin-angiotensin system. Atrial natriuretic peptide was first identified in 1983, and it kind of surprised me that, I use these every day, take it for granted, but they're really kind of new, diagnostic tools that have only come about in the past probably 20 years or so. The ANP was identified in the early 80s, and we have kind of 4 major natriuretic peptides. This one I found is kind of one of the newer ones. But ANP, we've heard all these before, synthesized primarily in the atrial muscle. BNP was initially found in the pig brains in the 1980s, hence its name. But it's mainly synthesized in the ventricles. CNP, C-type natriuretic peptide, usually in the kind of peripheral vasculature and the endothelial cells, more local vascular effects. And then this one called DNP. I'm not going to attempt this, but again, another one that's kind of produced in the atrium and less data on, but maybe one of the up-and-coming ones. So they all share this kind of peptide structure here. Kind of will focus on BNP, or brain natriuretic peptide, or B-type natriuretic peptide, depending on what you read. It's a 32 amino acid polypeptide secreted by the ventricles. The synthesis is also kind of important because it plays a role in some of the effects we'll see later on. But initially, it's a 134 amino acid pre-pro hormone called pre-pro BNP, encoded by a gene on chromosome 1. kind of the 25 N-terminal portion of it's removed, and that generates the prohormone that we've talked about, or we've seen before, pro-BNP. This is stored intracellularly in both ventricles. When the myocytes secrete this pro-BNP, it is then cleaved into an inactive NT-proBNP and an active BNP form, and these are secreted into blood in fairly equal amounts. And kind of the important thing here is, certain physiological insults cause the secretion, namely, volume overload and myocardial stretch. So again, another kind of schematic here. Eventually we get to this pro-BNP, which is stored in the myocardial cells. When these are secreted, it's cleaved into an inactive NT-proBNP and an active BNP. The half-life is different. We'll mention it briefly later, but the half-life of BNP is about 20 minutes. Of pro-BNP, a little bit longer, 1.5 to 2 hours. So we have natriuretic peptide receptors, two major types on cells that take up BNP, as well as endopeptidases that actively clear the BNP from circulation. So that leads to a shorter half-life for BNP itself. For NT-proBNP, there's really no known receptor-mediated clearance of NT-proBNP, so its half-life is longer, and it's primarily renal excreted. Interestingly enough, the NT-proBNP is more stable in storage, 72 hours at room temperature versus less than 4 hours for BNP. May play a role at times in, testing and depending on, what's available in the lab at the hospital. In general, both these are secreted equal amounts, but levels in the plasma of NT-proBNP tend to be 3 to 5 times higher than BNP levels. So it does play a role in, if you're testing one, the levels of one are going to be higher than the other one, and so you can't kind of interchange the levels. You can't compare a BNP level with the NT-proBNP level. You have to stick within the same molecule. A few slides, basics on the physiology. A lot of the stuff, again, we know, natriuretic peptides here. Multiple effects through different organ systems. Obviously by their name, these stimulate sodium and fluid excretion, hence the natriuretic and diuretic effect. They also have some effects on the myocardial tissue themselves, thought to inhibit hypertrophy and fibrosis. And again, if we think back to the pathophysiology of heart failure, we have some sort of insult to the myocardial tissue itself. These are, all these secreted products are the body's attempt to kind of maintain homeostasis and prevent further damage. And so at some level, these may prevent fibrosis that can lead to kind of remodeling down the road. It can suppress sympathetic outflow as well as simulate vasodilation. So all kind of, compensatory effects of the body to try to bring the body back to homeostasis. Again, kind of another slide to visualize this, some sort of myocardial injury leading to reduced cardiac output. And this causes decreased renal perfusion, activation of the sympathetic and the RAS system, and the natriuretic peptides kind of act over here to blunt this RAS system. Again, just another way to look at it. This one, again, kind of incorporating some of the natriuretic peptide A and B receptors, as well as the CNP, which is more kind of a local hormone effect on the peripheral vasculature. But again, natriuresis, diuresis, vasodilation, inhibition of hypertrophy and fibrosis, all these effects, are hopefully cardioprotective. How do we measure BNP? Usually by some sort of an immunoassay, kind of back to basics again, immunoassay. The whole principle is you're taking your substance that you want to measure, you're exposing it to antibody specific for it, antibody that's labeled with either a radionuclide or a kind of a ultraviolet immunofluorescent molecule, and you're kind of visualizing how much is bound. So again, back to here, our pro-BNP, once it's secreted, we have the inactive NT-proB and the BNP portion that's measured by these assays. Well, it'll come up later, but these assays also, there's not just these two forms that are secreted, but there's different truncated forms of this pro-BNP molecule that gets secreted, and these are also measured by the assays. So it does kind of cause some issues with measuring different levels of BNP and NT-proBNP with certain medications that we'll talk about. The first generation BNP assays were competitive radio immunoassays, diagrammed here. These required a lot of work with the sample. You had to extract it, you had to purify the blood sample. Then you went through kind of the competitive radio immunoassay. Then we had second generation assays. These were based on monoclonal antibodies and radioisotope labels. And really the main improvement was in sensitivity and precision. These appeared commercially in the early 90s, but they could take 12 to 36 hours for a result. The current assays we use are what are termed third generation assays. They were available in about 2000, NT-proBNP assays in 2002. And these are kind of what we call the rapid immunoassays. We can get results in about 15 minutes, and really all the current rapid BNP assays in the US are one of these third generation, of which there's several companies that make them. And again here, just kind of the schematic of we take our antigen, expose it either to a primary or secondary antibody, if it's a direct or indirect, attached to a molecule that fluoresces, and we kind of visualize the presence of our, the antigen that we're looking for. So how do we use BNP? Probably, the biggest use, and the one that we're all probably the most comfortable with, is certainly in heart failure. There's a lot of studies to kind of go through, but in general, both BNP and NT-proBNP have been clinically evaluated for management of CHF, both acute and chronically. In general, BNP concentrations in the myocardial cells are higher than ANP, so really BNP kind of took off as the one most intensely studied. And BNPs correlate pretty well, with the degree of LV dysfunction, and they correlate with New York Heart Association clinical class as well as prognosis. So we have pretty good data, at least for heart failure, of BNP being elevated with the clinical status of the patient. So patients with dyspnea, certainly undifferentiated dyspnea, when they present to the hospital, they have a lot of overlapping or conflicting elements in their history. Also, even physiologic or physical and radiographic findings can really hinder the differentiation between cardiac and non-cardiac causes, and that's kind of the question. The patient shows up to the ER: is this heart failure or cardiac dyspnea, or is it not? I think this is from like some of the Medscape article on the topic, but they mentioned initial misdiagnosis may occur in up to 20% of patients presenting to the ED with acute CHF, but initially misdiagnosed. Natriuretic peptides in the ED can be used to establish a diagnosis certainly when the clinical presentation is ambiguous. It's probably the biggest use currently. If the patient comes in with history of heart failure, multiple risk factors, they've got JVD, they have pulmonary edema on the X-ray, they're already at high pretest probability. And so really, the question there is not, a BNP level telling you if it's heart failure or not. It's probably in that case a BNP of more prognostic implications. But the younger patient who doesn't have other risk factors, no prior history of CHF, kind of this intermediate risk patient, is where BNP is usefully more for diagnosis in the ER, certainly acutely. 1994 was the study in Lancet that really first showed that this biomarker could help distinguish between cardiac and non-cardiac causes. This used one of the earlier generation assays, but really this was kind of one of the landmark studies that really brought this into clinical use, and that set into motion a lot more studies that we'll talk about. Namely, this was 2002. This was the BNP, or the Breathing Not Properly study in New England Journal. And what they looked at, it was a prospective study of over 1,500 patients coming to the ER with acute dyspnea. They used in this case, they used a kind of a bedside BNP assay, and really they stratified the patients out to the final diagnosis. Initially the ER physician gave them one diagnosis, and then two cardiologists later on during their stay, diagnosed them either with CHF or dyspnea-induced CHF or dyspnea due to a non-cardiac cause. The breakdown was here. And what they found was the accuracy of a BNP cutoff of 100 was 83.4%. A BNP value of less than 50 had a negative predictive value of 96%. And really they found of some other statistical methods that this was more accurate BNP itself than any historical or physical or lab finding to identify CHF. Some of the breakdown, so patients who did not have any congestive heart failure, their mean BNP was about 110. If they had dyspnea due to non-cardiac causes, but the patient had a history of left ventricular dysfunction, they had a higher mean BNP compared to those who had dyspnea due to CHF with the mean of 675. So we can see here, this already we're starting to see this risk stratification of even if they didn't have acute heart failure, but they had known left ventricular dysfunction, they had a higher BNP, kind of in the mid-range between patients with acute CHF and patients with no CHF at all. There's been a lot of sub-analysis of the study and the patients coming out of it. They also looked at BNP levels with New York Heart Association classification as well, and you can see certainly increasing levels as you get worsening NYHA class. Again, they kind of looked at the receiver operating curve with specificity and sensitivity, and really kind of see the effect of increasing BNP cutoff, lower your sensitivity but increase your specificity here. So we kind of eventually get to the point here where increasing sensitivity of a cutoff of about 100. Certainly under 50 is a pretty good sensitivity, but we kind of sacrifice some of the specificity with these. Again, this table broken out with negative predictive values, with different cutoffs based on their data. They also looked at multiple factors. So they looked at, certainly history of CHF, history of MI, all were pretty good at, identifying heart failure, but a BNP of over 100 had a much higher odds ratio. It was really the single highest factor they used compared to any other, even physical findings or history findings. So what do the current guidelines say? So 2013 was our most recent heart failure guidelines. So for ambulatory outpatient settings, so certainly patients with dyspnea, it's a class 1 recommendation to measure either BNP or NT-proBNP. They really don't make any preference one or the other. It's useful to support decision making, especially in the setting of uncertainty. It's also useful for establishing prognosis and disease severity and chronic heart failure. Class 2A recommendations, they talk about BNP guided heart failure therapy that we'll mention to achieve optimal dosing of medical therapy. And they also mention serial measurements to reduce hospitalization and mortality. For the acute setting and the hospitalized patients, so certainly again, measurement is useful to support the diagnosis of acute decompensated heart failure. Certainly, if you're kind of uncertain of the diagnosis, as well as establishing prognosis with these biomarkers, including troponins for heart failure treatment. Class 2B recommendations, so for CHF guided therapy using these BNP, it's not well established, but certainly reasonable to use it. And again, just the same table in different format. So again, we have good data for to diagnose or exclude heart failure for prognosis, as well as to stratify, less data for some of the biomarkers for fibrosis or for guiding medical therapy for heart failure. The 2012 European Society of Heart Failure Guidelines, they give some age-independent cutoffs, certainly to exclude heart failure, a BNP of less than 100 and an NT-proBNP of less than 300 are your cutoffs to exclude heart failure based on the European guidelines. They also mentioned this one per atrial natriuretic peptide that I was not familiar with, but they have another cutoff for that as well. So again, here you can see the levels for NT-proBNP are going to be higher than BNP levels, and you can't interchange them. And they also recommend using somewhat the same assay or just being familiar with what assay your hospital uses. So more kind of a contemporary article, 2015. This was a meta-analysis of the diagnostic accuracy of BNP in the acute setting. So they looked at a meta-analysis of approximately 42 studies. And at the lower thresholds that were recommended of 100 for BNP and 300 for proBNP, they had sensitivities of over 95% for acute heart failure, and again, negative predictive values of over 90% to exclude heart failure with these cutoffs here. And they didn't find any significant difference between using BNP or NT-proBNP. So for usefulness in diagnosing acute heart failure, you can take your pick. monitoring levels. So this is called BNP guided therapy. We do know that these levels improve as you treat heart failure, certainly chronic heart failure, and lower levels over time generally correlate with improved clinical outcomes. So, the randomized control trials of guided therapy versus standard care have really had inconsistent results. The successful positive trials usually enrolled younger patients and patients that only had HFrEF with a reduced ejection fraction. The positive trials also show that a lower natriuretic peptide goal or a substantial reduction was also consistently present. So, again, patients with HFrEF, younger patients, reduction of natriuretic peptides did show some positive benefits. There were 2 meta-analyses that showed that, BNP-guided therapy reduces all-cause mortality in chronic heart failure patients, certainly those less than 75. So that brings us to kind of what affects BNP levels, because there are some confounders that you have to be aware of. So certainly we're all familiar with some of the cardiac causes of heart failure, and like Dr. Harrison mentioned, it's not just heart failure, but valvular disease, atrial fibrillation, cardiac surgery, LVH itself, acute coronary syndromes, all can raise natriuretic peptide levels. But the other thing that we're interested in is non-cardiac causes. So advancing age, as you get older, BNP levels start to rise, anemia, renal failure, different pulmonary diseases, critical illness, sepsis, severe burns, or a lot of toxic insults, including chemotherapy. So these are things you have to be aware of and kind of take into the clinical situation whenever you're getting a value back. We'll talk about a few of these. First, renal insufficiency. Like we mentioned before, NT-proBNP is more renally clear than BNP. This is really the primary clearance of NT-proBNP. BNP also has some receptor-mediated clearances and the peptidases. So back to the breathing not properly study, they suggested, for a CHF rule-out cutoff of a higher cutoff of less than 200 if the GFR was less than 60. They did show that BNP levels were inversely correlated with estimated GFRs. However, they did exclude dialysis patients from that study. A more recent study, 2005, of ER patients with dyspnea, they found an inverse relationship between GFR and NT-proBNP and BNP. So they suggested, kind of CHF rule-out cutoffs of, 290 for GFR of less than 90 and 515 for GFR of less than 30. So again, different cutoffs, may be needed for different GFR cutoffs. And they also mentioned cutoffs for the NT-proBNP of, 1360 and 6550 for different GFRs. So, there's really no consensus of this. This is one study that needs to be studied more, but certainly to be aware of, and we've all seen it, BNP levels, more elevated with patients with renal insufficiency. So something you have to keep in mind and kind of add, you have to kind of take that into account when you're looking at a value. Obesity has a kind of an interesting effect on BNP. Again, it has an inverse relationship between obesity and BNP, and really this may hinder the utility of CHF in the obese. Again, in that same study, the mean BNP values were 3 times higher for lean patients with CHF 517 versus those with CHF and were obese, where they had mean values of 176. So again, a graphic here from the Medscape article that looked at the BNP study. You can see BNP levels here were lower for patients with higher BMIs versus those for lower BMIs, regardless of if they had CHF or not. Certainly the patients with acute CHF that we were worried about had a lower BNP cutoff. Another study, 2006, looked at medium BNP levels for different BMIs here. So you can see as you got over 30, this level was significantly different than level of a normal patient. Again, another table using some of that data. They kind of went through cutoffs. So certainly, negative predictive value of over 90% for our lean patients, but once our BNP is over 35, we certainly lose sensitivity and rule-out capabilities with the same BNP cutoffs, and this was using the cutoff of 100. So BNP of 90 in a patient with a BMI over 35 does not mean the same thing as if they're normal BMI. Again, they kind of extrapolated this data, and they suggested if you want to stay with a 90% sensitivity for cutoff for BNP, you had to lower your threshold to 54 if your BMI was over 35, or 110 for BMI between 25 and 35. So this is a more contemporary review that kind of touched on some of these issues and stuff that I certainly was not familiar with. So they do mention, why do we see this difference in BNP levels in the obese? So they do mention that the cardiac endocrine response is really pretty complex, and it's, you have to think about it as a result of several physiological interactions, namely, peptide levels, steroid hormones, cytokines, cardiovascular hemodynamics, clinical conditions, and pharmacological treatment. Gonadal function can regulate body fat distribution and cardiac endocrine function. Just visceral fat expansion can increase clearance of natriuretic peptides because you have increased expression of these receptors that take BNP out of the circulation on the fat cells. Obesity is also associated with ectopic lipid deposition in the heart, and this itself can have a lipotoxic effect on the myocardial, and they can secrete cytokines that kind of reduce the myocardial's ability to secrete BNPs. And just, practically, the obese are more likely to be treated for hypertension and cardiac disease with medical therapy. We know that medical therapy can lower natriuretic peptide levels. So all these taken together are partially to blame for the changes in BNP level in the obese. Another thing is brown adipose tissue, or kind of brown fat. Again, brown fat is kind of interesting metabolically with, thermogenesis as well as kind of a metabolic status, and a lot of factors play into increasing and activating brown fat. And from the heart, these natriuretic peptides can cause certain gene expression and thermogenic gene expression in brown fat. We know these act through certain receptors, and cold exposure can induce circulating natriuretic peptide levels and these receptor expression in adipose tissues they've found. So, cold exposure is one of the stimulating factors that leads to brown adipose tissue, certainly important in its role in hibernating mammals, but also may have a role in kind of metabolic status and weight loss and a bunch of other factors that we're just starting to learn about. Atrial fibrillation, AFib, can also confound the utility of BNP for acute heart failure. So even patients without heart failure, AFib was correlated with increased BNP levels. In one study using that same cutoff of 100, the specificity for heart failure was only 40% in the presence of AFib versus 79% in patients who did not have AFib. Again, this is from, I think, that Medscape article that kind of synthesized a lot of this data and came up with different kind of cutoffs depending on different clinical scenarios. So certainly, BNP of a younger patient less than 100 had pretty good, heart failure was unlikely with good likelihood ratios versus BNP of greater than 500, which is kind of currently our cutoffs currently. This, in between 100 to 500 is our kind of a gray zone or intermediate zone. NT-proBNP, our cutoff was less than 300. And then as we get older, certainly for NT-proBNP, we have different cutoffs as you get over 75. And same thing with GFR. Once you get under 60, our cutoff may be 200, and certainly over 500 as well suggests CHF. There's been a lot of studies for risk stratification using BNP. The Red Hot study 2004, they show that it was a strong predictor of 90-day patient outcome. The 90-day event rate was only 9% if the BNP was less than 200 versus close to 30% if the BNP was over 200. The Basel study 2004 showed similar mortality, but reduced hospital stays, reduced ICU admission rates if you incorporated BNP testing into decision-making process. So this is a group of patients who were admitted from the ER, and they kind of incorporated BNP testing to decide, was the patient going to go home maybe a couple days earlier, or were they going to be admitted to the ICU? So no difference in mortality, but you may have, may be able to get the patient out a couple days quicker, or avoid an ICU stay and its associated risks. Copenhagen Hospital Heart Failure Study 2004. Again, NT-proBNP level was predictive of 1-year mortality with heart failure, even though ejection fraction and heart association class were not in that study. Rothenberger study in 2004, annual mortality rates in patients with advanced heart failure, so a very sick patient population. These were, I believe, undergoing a transplant evaluation. those correlated with NT-proBNP levels. Another study, 2003, United Kingdom study group found that discharge levels was a significant predictor of adverse outcomes. And a Betancourt study in Circulation, 2004, hospitalized patients followed for 6 months. They found that the change in level was the strongest predictor of death and or a readmission. So that kind of led to, BNP use of prognosis after hospitalization. Some people advocate patients discharged with a BNP level of less than 300 to 400 have better prognosis than those with higher levels. And some suggest kind of a checking it, certainly on admission, maybe once at discharge and once during treatment to ensure that it's downtrending. For readmission, certainly it's a hot topic with kind of reimbursements getting looked at for CHF. We do know that congestion may precede kind of overt clinical symptoms by about a week. One trial looked at patients that were discharged after heart failure admission. If their 30-day BNP was rose to greater than their discharge level, this was the highest risk group for decompensation. And so it led to a lot of incorporation into kind of heart failure or outpatient heart failure clinics monitoring BNP levels and kind of intervening earlier if the heart failure is starting to trend up before the patient got overtly symptomatic. There are some home monitoring finger stick BNP assays that's being looked at as well. So again, one of the clinical uses could be patient monitoring of BNP levels, and the change, may precede clinical symptoms and a hospitalization. Again, this was published 2012. They kind of looked at, 10 years after the Breathing Not Properly study, what have we learned? This was the kind of current status of BNP use at that time. So certainly risk prediction in patients with acute coronary syndromes, ruling out CHF in the primary care setting, as well as some other uses that were kind of on the horizon. So at that time, the red bars were certainly the current uses of BNP testing at the time, and they predicted, 5 years down the road, we'd be seeing a lot of this use for patients with valve disease, outpatient risk profiling, even screening for left ventricular dysfunction instead of starting with the echo, and it was kind of guiding medical therapy. So we'll kind of end up with, one of the newer medications out. We touched on it before, but the Entresto, just the interesting mechanism of this leads you for discussion of kind of the differences between NT-proBNP and BNP and how they're measured. So as you know, Entresto is a combination of ARB with the neprilysin inhibitor. And what is neprilysin? Well, again, here we have our schematic of proBNP is cleaved to the active BNP and the inactive NT-proBNP. Neprilysin is an endogenous peptide that cleaves these natriuretic peptides into inactive fragments. And these, cleave a number of different substances, not just natriuretic peptides, but angiotensin, substance P, bradykinin, amyloid beta, into inactive fragments. That led to the theory of if we can inhibit this neprilysin, we increase the availability of natriuretic peptides to hopefully get an improved clinical response. So back to here, neprilysin cleaves BNP, but it does not cleave NT-proBNP. So, that would certainly lead one to believe that patients who are being treated may have higher BNP levels, as now you get less breakdown of the BNP and, maybe no change or decrease NT-proBNP levels. We're all familiar with the Paradigm HF trial that led to the approval of Entresto. This was a follow-up trial by the Paradigm HF study participants looking at those patients. And really the Paradigm HF trial looked at kind of mortality, and we saw the benefits from composite mortality of that, but they were interested in more of surviving patients, what did it have on the risk of clinical progression, as well as these biomarkers. So they looked at the same kind of patient population, and they looked at worsening clinical class, worsening symptom score by the patient, hospitalization for heart failure, interventions, as well as changes in these biomarkers in this population. And they found, not unsurprisingly, similar to the Paradigm trial, patients treated with this drug, they had fewer worsening heart failure requiring new drugs or increase in the diuretic therapy, fewer treatments for heart failure evaluation in the ER, less hospitalizations for heart failure, fewer multiple hospitalizations, less worsening of the heart failure class, as well as less patients considering themselves worse by the score. So all good, clinical outcomes. Also interesting is they looked at these biomarkers, NT-proBNP, troponin, BNP, and urinary cyclic GMP in this patient population, and they found that during treatment with Entresto compared to enalapril, patients had lower circulating NT-proBNP levels and higher BNP levels. So here, NT-proBNP levels, the white bar, the patients who were treated with the drug, the gray bar, patients who were on enalapril, and even starting at 4 weeks out to 8 months, they had a lower level of NT-proBNP compared to BNP levels, even starting as early as 4 weeks, they had a higher BNP level than the patients on enalapril. So again, it makes sense based on the physiology of it. And so they kind of, concluded that BNP levels reflect the action of the drug, and NT-proBNP levels, reflect the effects of the drug on the heart itself. So, that kind of leads it to want to think of, should we be measuring NT-proBNP levels in certain patient population? It's a little bit more complex than that. This is a white paper put out by, I think a Finnish company who makes a lot of antibodies, and that kind of came out with a technical paper on natriuretic peptides and Entresto, because it led to the question of, which one should be treated and how do we interpret these results. As you can see here, neprilysin degrades BNP. It does not degrade NT-proBNP, but it also degrades some of these pro-BNP truncated forms here. So, it's, even though, and these assays measure these forms as well, so you got to think about all this together. They mentioned that, really just saying, just measure NT-proBNP may be too simplistic. They give a number of reasons, one of which is that, this natriuretic peptide system may function differently in different forms of heart failure. And so this effect of neprilysin inhibition on natriuretic peptide levels could be varied in different disease states. Certainly in the HFrEF population, we have good data, but, how does it work in diastolic heart failure? Since the natriuretic peptide levels are a little bit different, the kind of intermediate range, does this still hold true? There is a diversity of pro-BNP derived peptides. So again, a lot of these immunoassays measure not just the BNP level, but these truncated forms of pro-BNP. And there's been no data showing that, neprilysin is capable of degrading the pro-BNP or these truncated forms. Elevated BNP levels themselves may inhibit neprilysin activity, so it confounds it. And increase in BNP may, might reciprocally reduce pro-BNP circulation and therefore NT-proBNP. So again, a lot of factors that kind of confound the view of just, saying just measure NT-proBNP on patients treated with Entresto, but just something to keep in mind of, if you have a patient on it, you may get some differences. So kind of a quick overview of BNP itself, some clinical uses. Certainly, how to use it, and some newer data with Entresto that I was not familiar with of, which one you may want to test for. So questions, comments?
Does anybody have any questions about NT-proBNP or BNP? So again, in our experience, we've been familiar with the WISE study that showed that women who come in the emergency room with acute cardiac events have less elevation of their troponin and are less likely to have a high troponin, but are more likely to have a high BNP or NT-proBNP. And so those patients we've been able to single out, and when we see a high BNP or NT-proBNP, we know that we've got a sick patient, even though the patient looks really fine at this point and the troponin is negative. We know it can be a very sick patient and can decompensate rapidly. So that's been a point. Let me ask Nick a few questions myself, and one would be, in practice, would you, after having reviewed this article, be prone to measure several BNPs or NT-proBNPs. That is, a patient's ready to be discharged, came in with rip-roaring congestive heart failure in high numbers. Would you measure this test before they go home?
In